Hey guys, Mike with FlightBridgeED. I've been an EMS training officer since 2008, and I don't know how many times I've had to deliver the bad news to someone about an expired certification. That means no work. That's where Piace comes in to save the day. Never be caught off guard again with an expired cert. Go to the App Store for your device and search for Piace, P-I-A-C-E-T, the one-stop application to manage and share all of your certifications. You know you don't want to be that guy or gal, and don't rely on your agency to tell you about your certifications. Go to Piace to manage your own certs and have some peace of mind. Download Piace today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. I just want to say thank you for staying with us and for continually downloading our podcast. You know, that is why we're here. We may do a lot of review courses, we may do a lot of education around the world, but truly the most important thing I feel like we still do is this podcast. It's been about a month since we put anything out, and I apologize for that. I've just been on the road nonstop. I've been waiting for this abstract to be published that we're going to discuss in this episode, and I really am excited about presenting this information. I have to applaud the authors, and this is a topic that has been a hot topic in our industry for the last 3 or 4 years. So the name of this abstract or this podcast is going to be this: Is ketamine a safer RSI medication in the pre-hospital transport environment? Well, we've really pushed this type of medication administration in the RSI setting in these peri-intubation or these really sick patients. We've definitely seen selection bias. We've seen providers go to that medication based on what we thought we knew, what we think we know based on the physiology of the medication. So the authors of this, the two core authors, Dr. Dan Davis, scientific advisor for Air Methods Corporation and FlightBridgeED's medical director, and Dave Olvera from Air Methods. Those are the two primary providers, and I have to applaud them for this study. So let's jump into it. Introduction. Rapid sequence intubation, we know, is associated with a number of complications that can increase morbidity and mortality. Among RSI agents used to blunt awareness of the procedure and produce amnesia, ketamine is unique in its classification as a dissociative agent. We know that ketamine has many, many actions. We know it blocks limbic and thalamic in our brain, those systems in our brain, and we know that that is based on perception and sensation. We know it actually blocks parasympathetic receptors like muscarinic and nicotinic, and by doing that, it actually optimizes and triggers our sympathetic nervous system to kick in. So we know we have a bump in heart rate. We're going to have some beta 2 stimulation as well, so some bronchodilation. We have an increase in blood pressure. And that is why, that is the basis, the foundation why we've used it or really pushed the use of ketamine in that sick patient that's hemodynamically unstable. So let's continue. The main goal of this analysis was to explore the incidence of hypotension and or cardiopulmonary arrest in patients receiving ketamine versus other agents during RSI. We hypothesized that ketamine would be associated with lower risk of hemodynamic compromise, particularly after adjusting for covariables reflecting patient acuity. In addition, we anticipated that an increase would be seen in prevalence of ketamine use with a decreasing incidence in peri-RSI hypotension and or arrest. So the authors basically looked at ketamine and they thought, you know what, we're going to have a better outcome. We're going to have less complications. Our patients are going to do much, much better. So the method was going to be a retrospective observational study using a large air medical database. Waiver of informed consent was granted by our IRB. Descriptive statistics were used to present demographic and clinical data. The incidence of hypotension and or cardiopulmonary arrest were calculated for each sedative and dissociative agent. A multivariable logistic regression was used to calculate odds ratios of both hypotension and arrest for each of the sedative dissociative agents. So what were the results? I think this is what's pretty profound to me. When we look at the specific medications that they looked at etomidate, they looked at ketamine, they looked at fentanyl, and they looked at Versed. The one aspect of this that I have to say, and I think this study is very strong, but I think there needs to be some follow-up data, follow-up studies, is the way this large airway database is captured is based on self-reporting during the charting phase after a flight. So there's a large amount of questions that are triggered based on specific charting criteria, and then those answers are completed. So, this isn't a randomized controlled trial. This is an observational retrospective study. So when we look at this, and as I said, we have etomidate, we have ketamine, we have fentanyl, and we have Versed. I think the thing that was interesting when I first looked at this is they, again, looked at 3 classifications. They wanted to measure how many patients desaturated, how many patients ended up becoming hypotensive, and how many patients ended up going in arrest. So for etomidate, N equaled 1,381 patients. So 1,381 patients were given etomidate. There was an incidence on average of 3.9% desaturation. There was an incidence of 0.5% in hypotension, and there was an incidence of 0.3% of patients with etomidate administration that arrested. So what does that mean? So in the etomidate patient, 0.5% of 1,381 patients is 69 patients. 69 patients that got etomidate ended up becoming hypotensive. I wanted to look at what that number was in the arrest category. And so for etomidate, 1,381 patients, 0.3% of those patients are arrested. That's 41 patients out of the 1,381. So we're talking about pretty small numbers. So let's look at the ketamine side. Ketamine side, and this is where we definitely know based on this data that there's definite selection bias. We have really pushed, I've been a part of that, we've pushed ketamine in these sick patients, in these hypotensive trauma patients that are hemodynamically unstable. Remember, how do we classify that? And this is something when I talked to one of the authors, Dave Over, about this study, is that he wanted me to remind everybody that the 2 factors that really tell us that these patients are just hovering on that thin line is a systolic blood pressure less than 80 and an end-tidal CO2 less than 25. And I think we should also remember shock index. When we look at shock index and we divide that heart rate into that systolic blood pressure, if that number is greater than 0.9, that tells us that we have a sick patient, that the potential for mortality is high. For these patients to decompensate is high. So with that being said, the ketamine group had 3,463 patients, so 3,463 patients, so quite a bit more than the etomidate group. 1.8% became hypotensive, so that's 62 patients. So in the hypotensive group, when you just compare etomidate and ketamine, ketamine had, almost 3 times the patients, but they had less that ended up hypotensive. So remember, etomidate had 69, ketamine 62. As far as the arrest category, 1.3% of patients out of the 3,463 patients arrested. So that's a total of 45 patients. So a few more, but when you look at the numbers and you look and compare of the total, so what is N? 3,463 versus etomidate was 1,381. So when you compare just etomidate and ketamine, I think in that subgroup, I think ketamine is still a better choice. So what about the fentanyl? We know that fentanyl if we go back about 5 or 6 years ago, that fentanyl was given in that peri-intubation phase to blunt the sympathetic response associated with intubation. But we started looking at the numbers, we started looking at the research, and we started thinking, well, maybe the fentanyl, by blunting the sympathetic response, was actually causing arrest. Maybe somebody, that's what they need. They need that sympathetic surge to maintain life if they're that gravely sick. So many protocols, guidelines around the United States pulled fentanyl back and removed it for that peri-intubation phase. But when you look at this study, there was a total of 1,733 patients that were administered fentanyl in that peri-intubation phase. 0.6% ended up becoming hypotensive, so that's a total of 103 patients. Okay, 0.4% ended up going into cardiac arrest. That was 69 patients. So I think when you look at the total numbers, I think maybe that thought process about fentanyl in that peri-intubation phase is correct. We have a higher incidence in total number of patients becoming hypotensive, and we had a higher amount of patients that ended up in arrest. And so I think that is not good. And then our last medication is good old Versed. Man, we'll go back a long time. Many of us have used Versed for years and years and years, but we know that there's much better medications out there nowadays. But regardless, N was 889 patients, so 889. 0.4% of those patients became hypotensive, so only 34, and 0.3 of those patients ended up arresting, so 26. So here's the thing. When you look at all these numbers compared to the total number of patients that received ketamine, I don't think ketamine did too bad. I think ketamine actually did very, very well. But here's the but. When you look at the overall outcomes, it didn't improve outcomes. It didn't improve patients' ability to compensate. It didn't change that. And I think that's where we have to be very, very cautious, is just to think that, man, I've got a patient that's sick, hypotensive, hemodynamically unstable. I'm just going to give ketamine. Remember, systolic less than 80, end-tidal CO2 at 25. That's the patient that we've really pushed ketamine on. And I think the thing that this abstract, this study shows us, is that it doesn't matter how sick the patient is. If they're that sick and you give ketamine, they're still possibly going to arrest. They're still possibly going to become hypotensive. Why is that? Well, here's why. Along the same lines of fentanyl, we know ketamine, as I said earlier, blocks muscarinic, nicotinic receptors. Those are parasympathetic, so it causes a sympathetic response. Well, again, if these patients are hemorrhaging, if they're decompensating, and they are just holding on with that last little bit of sympathetic surge, and then you give ketamine to these patients, and it increases O2 consumption, it increases cardiac output, it increases our blood pressure and our pulse rate, that could be enough to put them over the edge and cause them to arrest. So we have to understand that ketamine is a phenomenal medication, and it's being used in lots and lots of different types of patients, not just in the pre-hospital environment, and there's amazing results. But sick is sick. And I don't care what medication you give a patient, if they are that sick, they are going to decompensate, become hypotensive, and a lot of times die. So it goes back to this, is we have to treat our patients. We have to slow down, and I've said this on many podcasts in the last year. We get in a rush. We make the airway our emergency. And I can't stress it enough that we have to work off of our experience. The longer you do this, the slower you should become, the less it should rattle you. We slow down. We communicate with our partner. You communicate with the ground paramedics, or if this is in a hospital, the staff in the hospital, the RNs, whoever's assisting you or in the room. You slow down, you become that leader, and you take control. You resuscitate first. That means that if you're on scene for an extra 10 or 15 minutes because you were resuscitating with blood products, giving a little volume, maybe using push-dose pressors, then that's what you do. It's much better to have a patient alive with a perfusing pulse when you arrive at that receiving facility than have somebody in arrest because we are in a rush. And I think that is the big reminder here, is that out of the numbers, really analyzing the numbers, ketamine didn't do too bad. But ketamine is not the save-all, and ketamine still will cause hypotension and arrest. So how can we mitigate this? I think it's important to remember, if you have that blood pressure less than 80 systolic and total CO2 less than 25, maybe reduce your dose by half. So if you're using 2 milligrams per kilo for your RSI dose, use 1 milligram per kilo. Maybe even go down to 3/4, 0.75 per kilo. As long as you're giving a dissociative dose or even partial dissociative dose, then you're fine. But they don't need that full 2 milligrams per kilo in that setting. And so this is no different than what we've learned in, these patients over 50, 55, or anybody with liver disease. Anybody like that, you're always going to reduce that dose. This is no different. So think about it. Be, diligent in your medication administration. Understand the pharmacokinetics and dynamics. If you don't understand that, if that's a weak area, go back to the podcast I did on that, where we talked about plasma protein binding and how all that works, because I think that answers a lot of questions. So I will put this abstract, when it's actually totally published, in the show notes. This podcast is going to be released. It will not be on the website for a few days, so you'll have to download this via your phone, your app, your iPhone, your Android. And I will have this published with associated references as soon as I get all the data from the authors. If you have any questions, please email me at eric.bauer@flightbridgeed.com. I'd love to hear your thoughts on this, so feel free to email me, and I could definitely put you in touch with Dave Olvera and Dr. Dan Davis. So until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.